Well, I was instrumental in the formation of the New Zealand Manipulative Therapists Association, because Brian and I and those around us quickly learned that chiropractors were taking the bulk of patients with back pain, and that we would perhaps miss out if they succeeded in getting government recognition. So we formed the New Zealand Manipulative Therapists Association sometime after we formed the private practitioners, several years after. And that was for the express purpose of being able to say to the government that we have formed an alliance with the New Zealand Medical Association, and if doctors want spinal manipulation, they refer to physiotherapists. There's no need to register chiropractors or give them any official recognition. And that was the reason we formed the Manipulative Therapists Association. But all this time, I had been developing my own concepts, and I had to say to the manipulative therapists about middle of 1960, because I was the senior lecturer in spinal manipulation, I can't go on teaching something in which I do not believe to be in the best interest of the patient. If you can teach a patient to perform certain movements or adopt certain positions that stops his pain and enables him to control his own symptoms without being receipt of manipulation or mobilization, every patient should be entitled to that information, and all therapists should be obliged to provide it. Well, having been instrumental in forming the manipulative therapist, it was heresy to now turn around and say, keep your hands off. Educate the patient, perform these movements repeatedly. As you do this, is your pain getting progressively worse or progressively better? Or is it changing its location? Tell me about what's happening. As you repeat this movement, the patient tells you it's getting better, it's getting worse, it's not changing, or it's moving to the middle, or it's moving further down the leg. You know what to do. And then you say to the patient, you must do this. You find the movement that centralizes his pain, or stops his pain, or reduces his pain. This is the movement you must perform 2 or 3 times a day, 5 or 6 times a day, if necessary. 10 or 12 at a time. Treat yourself. Go and treat yourself. So that's why I came apart from the manipulative therapist. I exhaust all possibilities using the patient's own movements and positions before you apply external force. When you've exhausted all the patient's own potential, you may need to add more pressure with your hands. So there's a time when manipulation is necessary. When the patient says, I've done the exercise, I feel better, but within an hour it comes back. More force required. Add progressions. Force progressions, as we call them. But osteopathy, chiropractic, Carlton-Bourne, Maitland, Brian Mulligan, Stanley Paris, have all persisted with the hands-on. And I have stated that, as I have just said, keep your hands off until you've exhausted every possibility using the patient's own movements and positions. And I reckon you have to put your hands on in about 1 out of every 10. And that's why this thing has been embraced by the medical fraternity, because it's not just another system, it's not another system of manipulation. The world doesn't need a 5th profession that's involved, or a 3rd profession that's involved in manipulative therapy, because the difference is only in philosophy. Chiropractors believe they are reducing subluxations by giving an adjustment. Osteopaths are manipulating the spinal lesion, whatever that might be. And Maitland and Mulligan all believe they are mobilizing joints and improving range of motion, but without necessarily using the patient's own system. Now, those results that I described in my book have now been replicated hundreds of times, thousands of times. So why is it different? It's different because the assessment process, which is found to be reliable, validity has been established, reliability has been established, that a well-trained therapist can get the same results. That the assessment process, if no movement or position can be found to reduce, stop, or centralise the symptoms, no movement or position can be found to reduce, centralise, or stop the symptoms, the patient is probably unsuitable for mechanical therapy, because the assessment process using repetitive in-range loading will expose the difference between derangement and dysfunction. Contracted tissues don't normally cause pain in the neutral position. Contracted tissues object when you move them beyond a certain point. You move back off that and it stops. So you can identify a dysfunction or contracture or adaptive shortening by moving the patient to end range. Stop when it hurts. Stop. Go further. Go further. I can't. That's the end of it. Come back upright. What's happened? No different. Bend forward. Still there. Up you come. With derangement, you repeat movements in certain directions. Repeat flexion, they usually get progressively worse. Repeat extension, they usually get better. Majority, probably 60% get better with extension. Maybe 70% get better with extension. In lateral flexion, you'll need to lateral flex 10 or 15%. But the movements that centralise the pain have now been found to be reliably a good prognosis. We've got a couple of thousand references now which have investigated all the various aspects of it. The assessment process is now written into the guidelines in Denmark, in the official disability guidelines in the States, Texas and California to start with. They recognise the McKenzie system as diagnostic of disc disease, disc problems, and they recommend the treatment. So gradually the evidence is being compiled.